Thank you very much. Thank you. This is, I suppose, trying to reflect some of our earlier speakers, and they've been talking about how the big systems have changed and try to support us, and Peter Johnson's been very clear. This is more how was that put into practice in our cancer sector. So we're part of the North West London, South West London Cancer Hub, and we worked in partnership with Royal Marsden to try and maintain our cancer surgery. Part of my role is very much trying to look at the organisational structures. We've heard a huge amount about the disruption that's come to individual cancer patients. From my lens, one of my roles was to try and make sure we captured that in a logical, rational way, and how we could assess harm. We've talked a bit about harm of patients who haven't yet been diagnosed or who are waiting to be diagnosed, but we do have to keep logging deferred treatments and change of treatment plans in the post-COVID and during COVID that were different from a gold standard that could have been expected pre-COVID. So we organised and changed our MDT structures, and we very rapidly looked at every single cancer patient on our entire cancer PTL and pushed them through a very structured MDT to capture gold standard treatment, change of treatment plans, and most importantly, to capture when they needed to be re-reviewed again. This enables us in the back office to make sure we can track that and represent these patients to the clinicians so that they don't need to worry about that aspect of the patient care. Cancer surgery, we did very similar things through all our cancer patients and our urgent benign, but particularly in cancer from this point of view. The data from Italy very early on said we could maintain cancer surgery if we used COVID protected sites and pooled all our resources to maintain and very specifically maintain those as COVID protected. So we actually transferred patients and staff out who tested COVID positive. And in that, in our cancer hub, we've really managed to do well over 700 cancer surgeries, nearly 1,000 actually to date in the last look. And that was through our independent sector partners and our Royal Marsden partners. We in the Trust also maintain very urgent sort of P1, P2 surgery at all times if we needed that co-location experience. But again, it was that ability to track and log all in a very logical way what was the priority and what were the harm that we may be inducing potentially through the deferred treatment. And that's given us a new matrix. We can track that through our electronic EPR, we track it through Somerset, and it means that we have quite a lot of confidence that we haven't lost any patients who have had a change in treatment plan and that we need to keep revisiting and relooking at. The real challenge now, as many other people have talked about, is capturing what went well, all our remote working, all our innovative ways of doing outpatients, of reviewing patients, but also trying to now restand up our internal systems. And huge thanks to all colleagues who are working on that through Imperial. Oncology pathways seem to be the more simple to stand up. They're a more defined patient group, and we only have 1 or 2 chemotherapy and 1 radiotherapy centre. So it is a much simpler system. However, we do have a tremendous backlog and some very frank conversations about whether the chemotherapy would beat individual patient. In surgery, people have already discussed very complex diagnostic pathways. We do have a backlog of thousands of CT scans and MRIs that have had to be deferred for 3 months. And again, we're going through a priority and harm rating to make sure we are doing the really important ones all the time. But the diagnostic piece is vital, and we need that up and running before we can really turn our surgery on to the highest capacity. We've stood up by using our independent sector partners for using the high volume, low complexity surgery. We're really skilled at that. We have used them a lot in the last 3 months, and we are continuing to use that pathway for those kind of patients. And internally in the Trust, we're going to focus much more on high complexity surgical cases that need our coexistent adjacent specialities like ITU or neurosurgery or renal colleagues. So that was our approach to making sure we can stand up, but it's really underpinned by, for us, an innovative cancer harm and priority scheduling matrix, which means we can very easily track and pull thousands of patients through the system and find the ones that need tracking and treating immediately.
All right,
Thank you.
Catherine,